because we are very curious how you deal with these subtotal occlusions of the carotid.
So, dear colleagues, it's great pleasure for me to be part of BEC 2025, and here is my topic about coronary artery stenting in case of subtotal carotid stenosis. The definition, the condition subtotal carotid stenosis was first described in 1953, almost 70 years ago, but till today there is no universal definition of this condition. Most constant definition that can be found in the publication is actually collapse of the internal carotid artery following critical stenosis of the internal or common carotid artery, and plenty of synonyms also can be found. Near total occlusion or subtotal stenosis are most frequent of them. There are four most frequent criteria for subtotality of carotid occlusion, and here you may see it: late contrasting of internal carotid artery distal to the stenosis, smaller distal diameter of internal carotid artery compared to contralateral one, also presence of intracranial collaterals. Here you can see part of collaterals of a circle of Willis, and distal diameter of ipsilateral internal carotid artery that is equal or even smaller compared to the external carotid artery ipsilaterally. Actually, there are two types of near occlusions. One of them is near occlusion without a complete collapse, but actually the real near occlusion that carry the prognosis of the disease are the near occlusion of the carotid artery with full collapse of the carotid artery distally to the occlusions. Back to the 1991 in the NASTED trial, in one of the post-hoc analysis of the NASTED trial, this occlusion with full collapse distally was seen as benign, probably because of the low probability of the thrombus to detach and go intracranially. Nowadays, we know that actually this is not true. There are a very small number of patients with near occlusion in these trials. So nowadays we know that each carotid stenosis can progress to near occlusion, and each near occlusion can progress to the total occlusion. In most of the cases, histological finding of near occlusion is similar to high-grade stenosis. However, in some cases there is thrombosis with vasovasorum in these lesions. The huge game changer in this situation are collateral blood flow, circle of Willis on first place, and also we must not forget of the collaterals on the ophthalmic superficial temporal artery and meningeal collaterals. We know that actually the collateral circulation in this situation is not good in order to estimate the perfusion of the brain. For example, MRI perfusion is far more precise method. However, collateral blood flow is available on site without additional delay and can be used by the operator in order to orientate. For example, in case of 50 to 70% stenosis that is not severe according to the NASTED and ESCT trials, there is only 3% of frequency of collaterals. Up to near occlusions, there are more than 60% of the patient with collaterals available on angiogram. So as conclusion, I can say that subtotal occlusions are theoretically related with low stroke risk because of the lack or very low antegrade blood flow, and at the same time theoretically related with higher risk of complication. First of them, brain hyperperfusion. So based on that and the fact that NASTED and NCT clinical trials include very small amount of patient, you can see on this slide only 16 patients with near occlusion in the whole NASTED trial that is actually cornerstone for treatment of carotid stenosis. and the fact that only classical surgery is considered nowadays, here we can see the recommendation in European statement and also the US statement. At all, if you have occlusion or near occlusion according to the European statement without recurrence of stroke or only one incident, best medical treatment is considered with 1A recommendation. In US statement is a little bit different. However, there is no differentiation between near occlusion and every high-grade occlusion, and the treatment, stenting or endarterectomy, is recommended only in case of recurrent stroke of the patient. The things are not so binary, as we know at AFCOP and ISCIATI trials, also of the CREST trials, because there is no only the problem stroke or TIA or not stroke on TIA in this patient. Carotid stenosis itself, I'm talking about carotid stenosis at all, severe carotid stenosis, not only total occlusion, is related with cognitive decline of the patient, which makes the things a little bit sophisticated. First data against the conservative behavior in the near occlusion is actually back in the 1983, first small series. Then the huge game changer is publication from 2015, meta-analysis from Greece that compares best medical treatment with carotid artery stenting and carotid endarterectomy. And the stroke incidence ratio is reported to be 1.6 in case of carotid stenting, 2.2 similar in case of endarterectomy, compared to the incident ratio of more than 6 in case of best medical treatment. So actually, this is the first meta-analysis that gives us some point to intervene carotid subtotal occlusions. Another publication, another meta-analysis based for even more 33 publication was published 5 years later. The results are very similar, with incidence ratio in case of surgical treatment far more better compared to the best medical treatment. And what is actually important, and you can see on this slide, is the fact that the authors also report significant difference between the complications according to the year that study is performed. So back to 2005, there are 33% more complication during the stenting of subtotal carotid lesions than in 2020. Here is the last thing that I'm showing you about the clinical trials. 2022. It's a huge trial, biggest one, 639 patients with subtotal carotid stenosis who underwent stenting or of this stenosis. And the conclusion of the authors is actually that stenting of near occlusion is not associated with increased risk of complication, which is the huge game changer, because actually this gives us the opportunity to treat without fear of exclusion. Here, these results actually makes us to form our little series with patient with carotid occlusion. It's actually a trial, string trial, that is registered in trials.gov. We investigate patients with subocclusive string signs, near occlusion. We perform MRI perfusion in order to estimate the ipsilateral perfusion deficit of the patient. We include primary, more than 75% patients with ipsilateral stroke. However, we have also a group of patients without stroke, only MRI perfusion deficit. Actually, during the protocol, we estimate the cognitive status of the patient before inclusion into the trial, after the procedure, and 6 months after the procedure. MRI perfusion was repeated 6 months after the procedure in order to prove if there is some some benefit for the patient's brain perfusion. Here you can see the flow chart, the things that we do at the beginning, screening of the patient, the procedure, including some biomarkers, and third and 6 month follow-up of the patient. It's still ongoing trial. So actually that's the flow chart nowadays, 57 patients till February this year. 37 of them was male, and most all of them was hypertension patient, 83% with TIA, 33% with stroke. Here is also overlap, patients with TIA and stroke, and none of the patient with hemorrhagic stroke before, which is actually exclusion criteria. Crossing the lesion, the subtotal carotid stenosis, was performed in almost 90% of the patient with hydrophilic wires. In most of the patient we use, to be honest, coronary hydrophilic wires. In 30% escalation of the wire with Gaia first or second or conquest wire were necessary, you know, in order to cross the stenosis, and we have implanted more than one stent in actually 2 of these 57 patients. And here are our results till this moment, which are quite good. We have one clinically significant ipsilateral stroke with MRSA decline of the patient after the procedure, one death, and after actually another stroke that is unfortunately because of the bleeding, and unfortunately this patient died. But however, in our series of 57 patients, these results are not so bad. And just a few slides, here is one single 68-year male with a recurrent TIA and MoCA deficit, with subtotal occlusion of the left carotid artery, and as you can see, a massive collateralization during circle of Willis and also during external carotid artery. We performed the procedure with its Fielder XTR, its coronary wire, crossing the lesion, then pre-dilation with a very low profile, again coronary balloons starting from 1.25 up to 3 millimeters, then placing the distal protection that is Spider F Hicks, as you can see at the right, making one by one dilation with 5 millimeter balloon, or almost one by one, and after that implanting its exact stent, 9 by 7 by 30. And this is the result immediately after stent implantation, also intracranial. So as conclusion, I can say that neuroocclusions are related with a high rate of cerebrovascular ischemic incident compared to non-significant stenosis, and also the guidelines nowadays have a very conservative recommendation about their treatment. However, recent data shows the benefit of stenting or surgical treatment of this occlusion, and maybe we will need a little bit more information about that, which patient to treat aggressively and how to select the patient for the treatment. Thank you for your attention.
Thank you very much for that really wonderful overview, how to proceed with nearly occlusion. Are there questions or comments you have?
Because I have 2 practical questions. Very often when we have this critical stenosis, there is a suspicion that there could be a thrombus. Do we need to evaluate this with some RA imaging, or it's not necessary? I mean, the string line sign is always associated with thrombosis, which is not always a good option for, I mean, for...
Yes, during the histological seria, in up to 20% of the cases, there is thrombosis. So angiographically, we see subtotal stenosis. However, the histological finding is thrombosis. Yes, I think that anyway, it's better to perform MRI. In order to intervene this lesion, it's better to perform MRI in any case. A little thing, you do something that is actually controversial, that is actually against the guidelines. So anything that can support the idea for the treatment, and anything that can do safety considerations such as excluding thrombus inside is good. Unfortunately, this makes the procedure itself expensive.
It's not obligatory to have a City, for example, just to clarify where it's thrombus-containing lesion or not.
Yes, City is obligatory. Yes, I think City is obligatory. Also on the City, you can have additional information about the aortic arch, for example, because in such procedure, you must be on the safety side. And in such procedure, you must very good plan your approach, and you must, how to say, expect difficult crossing of the lesion. So support is mandatory.
Thanks. And the second, it's a comment probably, because this is not near occlusion. These are really chronic occlusions, because the gyres that you use in about 10%, 7% of cases, these are Gaia, these are Confianza, Conquest, which chronic gyres for chronic total.
Excuse me, only 10% was with Gaia escalation. Yes.
I mean,
probably the histological finding on this patient is total.
You have to use such wires. They are between 9 and 12 gram thickness, stiffness of the tip. That means that what we hear is what we see is what is just some collateral and vasovasorum. If you have to cross this with this. So
probably, however, the recurrent symptomatic of the patient with the MRI perfusion data of ipsilateral hemisphere hyperperfusion. And the fact that in most frequent series, the reported incidence of ipsilateral stroke in case of near occlusion of occlusion probably is not hemodynamic phenomenon, but probably it's embolic phenomenon. So yes, you're completely right. In this patient, we use also very weight and stiff tip wire, CTO wire, and also we use the bone for support as a catheter, which makes the wire extremely stiff.
What is also helpful is use a balloon-tipped sheath, so you can, before you pass the internal carotid artery, block the flow completely.
For anchoring.
So you have no also great flow to the cerebral arteries, and then you can produce an under pressure as when you have placed your stent and dilated the lesion, so you get out the blood, which is there with all the possible tiny particles. There is also a question here, Professor Grunwald. Please.
So let me congratulate you on your wonderful study. One comment regarding thrombus inside. I think now that we have proximal protection, we have an additional safety and feeling of safety when we treat these lesions. So from our experience, when we did testing on carotid and on cognitive changes in the carotid, two things. So when you do the carotid tests, there's the difference between cognitive speed and memory tests. We found that the most significant ones was the Stroop test, for example, because often those tests are then all put together, and that's why many studies have found there is no big difference here. There are different tests, like someone who's elderly, they may remember everything from their childhood, they may not remember what they had for lunch the last day.
Yes.
So a different kind of memory that we're looking at. We also then continued using functional imaging, functional MRI for those tests. And because we were wondering why there was no difference between our patients that improve, whether they were stented on the left-hand side or the right-hand side, because I would have expected with right-handed patients, they were all right-handed, that there would be more in the dominant hemisphere. That was not the test. So we could see that the area that was most responding was the area of the anterior cingulum, which is supplied by both sides. And what is now working even better, and that is what I would encourage you to add, is adding resting state MRI, resting state fMRI, where you're actually not even dependent anymore on a paper pencil test and whether the patient had their coffee, but you can exactly see the response and you see the connections forming. And we did that in 58 patients. Unfortunately, I then left the center and we never published it. But that was and we also compared it to asymptomatic aneurysms at the time, and it was highly significant. So I would encourage you to add fMRI, resting state fMRI, to the test protocol. It's about a 13-minute protocol that can be done on any scanner, yeah, to include that. Thank you.
Thank you
congratulations,
very much.
It's really important.
For advice.
Okay, thank you. Other questions? If not, yes, congratulations, and we go on in the program.